Hello, everybody. We are going to go ahead and get started. The snow is starting to pile up out there, and Dr. Savros has some really great information to share with us. She actually just said, I took some slides out this morning at 5 o'clock because I knew how bad the weather was going to be. And so for those of you who stuck around, thank you. We do appreciate that. We do know the weather is bad, and so we're going to try and wrap up as soon as we can to get everybody going. But with that, my name is Jane Neubauer. I work with the Early Childhood Dental Network. And we actually invited Dr. Savros here today to talk with us about the importance of oral health over the lifespan. And she spoke earlier about, the importance of that prevention piece and early intervention. And she is a pediatric dentist, so she sees children every day. And I think that she has a great message. So let me turn it over to you, Dr. Savros. Welcome.
Thank you so much for having me. As I said, I took out some slides this morning so we could wrap this up. Everywhere else I've ever lived, this is called a snow day, and everything shuts down. So we'll make this informative, but quick. Like Jane said, I am Elise Sarvis. I'm a pediatric dentist at the University of Minnesota. I did my dental training at North Carolina, and then my residency in pediatric dentistry and public health in Seattle. So I'm collecting all the time zones at this point, and I just have mountain left to get at some point. So I just wanted to talk a little bit about the lifetime importance of oral health, and I know everyone here is very invested in oral health, or else you wouldn't be here on this lovely Friday afternoon. But what it means, and things you can take back to your communities and take back to sustain you through this very good mission that we have to improve the oral health of Minnesotans. So I haven't been in this game very long, so I have no potential or actual conflicts of interest to declare. I thought I would give you just a little bit of context of what you're doing every day in your communities. And this just gets a little bit of background, both biologic, like the dental biology, but also just some of the social aspects. So I'm a pediatric dentist by training, so I see children on the individual level. But pediatric dentistry is the only specialty that is population defined. So all the other specialties, endodontics, ortho, perio, they're all defined by places in the mouth. Well, pediatrics is like a population. So when I was doing my residency, I sought out extra training in public health because this is the study of populations. And so being a pediatric dentist, I wanted to treat the population that I was specializing in. So this is to give you some background too. On the days that it's hard to find funding, it seems like you're always fighting an uphill battle. You keep seeing children with oral health disparities. This should sustain you because what you're doing, you have a wonderful mission. And your work and your dedication now will help not only children today, but it will help them in the future, and it will also help their future generations. So you have a wonderful mission that you've dedicated yourselves to. I wanted to go over briefly what a LifeCourse Theory is. So LifeCourse Theory is a public health idea that was developed in the 1960s. It has some origins in the 1920s as well, when Polish immigrants were coming to the US. And so researchers were seeing that Polish immigrants who were poor in Poland remained poor in the US, and there wasn't a lot of change. So the researchers were trying to figure out exactly why that was happening, and why over generations the health disparities and the social disparities stayed the same. So they developed this thing called LifeCourse Theory. And what it is, it's a framework that looks at the trajectory of a lifespan. So it looks at different points in that lifespan and sees, does the health, does the life, does the social situation of that person get better? Or does it get worse? Or does it stay the same? Or does it go up and down? So it can look at exposures at various points in time. So what happens to make that trajectory go up? What happens to make that trajectory go down? Is it disease? Is it a social context? Is there inherent racism like apartheid in South Africa that causes the trajectories to change? Is it a social economic position of the time? Is there a recession? Does that cause these trajectories to change? Oh, this is not. There we go. And then it looks at those trajectories and measures outcomes on those trajectories. So you can measure the trajectory based on disease or health or quality of life and things like that. So it's a pretty intuitive theory, but it took a while for it to get all accumulated. And so what it looks at is the accumulation of risk or protective factors, and that can change a person's trajectory over time. So it's not just one event that puts you on a trajectory, it's a multitude of events, and things change, things balance, things get out of balance. So dental disease is really nice to look at in this type of context because, as we know, dental disease is progressive. A cavity starts, it gets worse, it gets worse, it gets worse. It's cumulative. You lose one tooth, you lose another tooth, you become edentulous. So it fits really well in this framework or model. Children who are at high caries risk are often of lower socioeconomic status, are often of color. Those risk factors can cause other things in their health life to change as well and to be on a poor trajectory. So those children might be destined to have poor oral health and lower quality of life based on our knowledge of this disease process. But when you look at this framework, I hope you know where you can make the impact that can change that trajectory, that makes that destiny not be set in stone for these children. So I like to give examples from kind of just medical literature. We work a lot with our pediatrician colleagues. So just to kind of give you the example of what this trajectory looks like in a very common disease process, we all know that smoking in pregnancy isn't the best for both the mother and for the fetus, and that can cause low birth weight babies. And low birth weight babies have a host of physical problems that just are inherently happen because they are born early. So they have respiratory disease, impaired brain development, they do poor in school, they have abnormalities in how they process thinking, which in the future can lead to lower socioeconomic status in adulthood, so trouble getting jobs, trouble holding jobs, and it comes with a whole host of adult problems. So you see how this one thing that happened in the very, very beginning of their lifespan can have implications further along. In this framework, you can see two things that really hit home. One is the smoking in pregnancy, and the other is being born low birth weight. So they're related, but those are two really critical time points. And what we call those time points are critical or sensitive periods. So right at the very beginning, things that happen during those have an abnormally large effect later on in a person's life. So, detrimental things happen. You in dentistry, you eat too much sugar like one weekend and you have your acid levels go up on your tooth and you might have some decalcifications. Okay, that's just like one point in time. But if bad things happen at these really critical times, if you have childhood caries really early on, it can have much greater implications down the road. So these critical points are adverse events that happen in those really sensitive time periods. So I kind of divide these into two, one's in the fetal stage and one's in childhood, and we'll talk about what happens in oral health for these. So dentistry starts very young. It starts even in the embryologic stages. And we know that a woman's oral health can affect the health of the baby developing inside her. So when we talk about preventing cavities, we have to start even before the child is actually born. The hormones of pregnancy can exacerbate otherwise just benign oral conditions like gingivitis. So the hormones going around a woman's body while she's pregnant. If that happens and she's unable to brush her teeth or she has plaque, the body actually has an extreme reaction to that plaque and can cause some significant gingivitis and periodontitis that it normally wouldn't have. There's a lot of myths about pregnancy in dental care, even in this information age that we live in. Some of these are social and some of these are cultural. But a lot of people say oh, I can't go to the dentist because I'm pregnant. Well, that's not true. Actually, it's a great time to go to the dentist because you want to get things cleared up. Dental care should not be postponed during pregnancy. So pregnancy comes with its own host of other things, like increasing craving sugary foods, which we know can exacerbate oral conditions. That's one of my favorite pictures because I really like sprinkles. And like I said earlier, pregnancy hormones can cause gum swelling, so it's a reaction to that normal oral microbiome that just gets really exacerbated in pregnancy because of those hormones. So they can get really big buildups like pregnancy epulis or epulis fistulatum, that nice kind of, my pointer's not working, but everyone can see it's the big puppy thing that's not teeth in that picture. Also in pregnancy, women may experience nausea and vomiting, which can coat the teeth in extra acid and erosion. So all of these things kind of come to play in a time that we don't think about affecting the baby years and years and generations down the road. But this time is a really important time in oral health. So I like to give some fun facts to the dental students. Women can see a dentist at any time during the pregnancy. Radiographs are safe to take, especially if they're needed for an emergency procedure. You'd rather get that infection out because that infection is in the mother's bloodstream and could be transferred to the fetus. You can use local anesthetic during pregnancy. It's a Class B drug. And then you can place a variety of types of fillings, including amalgam or silver fillings during pregnancy. There's no evidence that that type of mercury will cross the placental barrier and harm the fetus. And like I said, delays in that treatment might actually harm both the mother and the child. There's a really big increase in periodontal disease in pregnancy, just given that extra exacerbation of the body. And that periodontal disease has been linked to preterm delivery. It's been linked to low birth weight babies, which has the same effect as children who are exposed to cigarette smoke in the womb. So those things can carry on throughout their life. And you can also get placental structural abnormalities. They've done histologic slides of the placenta, and it's not as normal as you would expect in women who have periodontal disease. So helping the mothers at this stage is really important for helping the babies years down the road. Also, baby teeth start to form when children are in their mother's womb. Baby teeth, does anyone have a guess of what month they start to form? Fifth month. Anyone else? It was really close. It was fourth month. So early on in the pregnancy, teeth are starting to form and starting to calcify. These are a little, this is when they start to calcify. So they're forming even earlier than the fourth fetal month. And these are baby teeth. These are baby teeth that these children might have until they're 10, 11, 12 years old, are starting to calcify so early on. So making sure that everything is optimized in the mother in this stage can help this child years down the road. Since those teeth are beginning to form, whatever the health of the mother is might also affect the child. So maternal malnutrition is linked to enamel defects. And so these enamel defects are tiny little pits in the enamel. And you can kind of see it on this lateral, that little hole, where this enamel doesn't form quite so well. And on a microscopic level, this is what it looks like. So not only is the outer surface of the tooth weakened and more susceptible to decay, but that little area is really hard to get a toothbrush in. And so you can get a haven for microbes just hanging out in that little area. So mother's health can affect the child many, many years down the road in this very critical, sensitive period. Permanent teeth are also starting to be formed at this time. So the calcification for most of the permanent teeth, these central incisors that you have in your molars, they happen around birth, like in the first few months after birth. So you can imagine if it's a traumatic birth, if it's a birth that comes with a lot of complications, that the disturbances in that enamel might happen years down the road. And these are permanent teeth, so ideally the child will have these teeth for the rest of his or her life. So you can see these are, this is a condition called enamel hypoplasia, where the enamel doesn't quite form so well, and it's weaker and more susceptible to decay. And these are permanent teeth in the back and primary teeth in the front. Oh, I do have a pointer, so here we go. So you can see and you can realize that, things that happen even before the child is born or at that birth event have consequences years and years down the road. So that's the fetal sensitive critical period. In childhood, we also have a lot of things that will set a child up either for great oral health for the rest of their lives or not so optimal oral health. The first happens really in this infancy stage, and how many times have you seen parents clean off the pacifier that dropped on the floor with their own saliva, or share sippy cups, oh, the kid wants to give you a drink and it's really adorable, and you're like, okay, I really don't want to share saliva. Because what we find is that caries is an infectious disease. It's a transmissible process. We have some really good research that says, a lot of the bacteria that children have in their mouths comes from their mothers. And now that we're doing even more research in this field, we're finding that it comes from their fathers and their grandparents and the kids at daycare. And kids are they're very sticky and salivary. There's lots of spit going on, lots of exchanges. They love to share, right? It's a good thing you teach children is to share, but sharing germs and sharing those caries that the bacteria that cause cavities, maybe not so great. And it's setting them up for even things later on down the road. So we know that children with especially the severe early childhood caries have caregivers with caries as well. Which are thinking okay, they've shared these germs, but they're baby teeth and they fall out. But we actually have a couple of longitudinal studies that say that this happens between generations. So there's a study that looked at some 32-year-olds in this nice little cohort, and they looked at their oral health today when they're 30 years old. And they looked back and it correlated to what their mother's oral health was when they were 5. So the transmissibility of oral health doesn't just like stop at childhood and infancy, it's perpetuated throughout this like lifetime. And this, it's not just transmission of caries, it's also transmission of oral health beliefs and socioeconomic status and hygiene habits and things like that. But just understand that what happens in childhood has effects much, much later down the road. These studies are really hard to do because you have to follow people for a very, very long time, and you have to actually like go out and look in their mouths. So a lot of times these get tacked on to other studies. And sometimes like if you're looking for things as a researcher, what you're looking for might not happen in your lifetime. So just understand that we don't have a lot of great like solid primary data for this, but the data we do have does suggest that there is some intergenerational effects. So in this study out of Norway, they looked at the parental dental status when the child was 10 years old, and then like looked at it over time, and whatever the child's parents had at 10 had implications to when the child was an adult, even in different time periods in Norway, which Norway is doing a lot of different changes in socioeconomic status at that time. So these effects kind of went over those different time periods. I think we need more longitudinal studies or tack oral health onto more longitudinal studies. You've seen, and I know you all are like so good and tapped into the oral health community, but a lot of times we'll do studies and forget about oral health, or people have early childhood initiatives and forget about oral health. So keep fighting the good fight to like get oral health into the medical model of things. So I see a lot of dental disease, and I see lots of teeth with holes, and what hurts most is that this is fairly preventable. It's not preventable for everyone, but you can change the course and the trajectory of a lot of these children. We know that poor oral health in the school age is associated with a lot of adverse events, such as insufficient physical development, loss of school days and falling behind, diminished ability to learn, restricted activities, and a diminished oral health-related quality of life, which might actually be one of the most important metrics of all. If you don't feel like your oral health is good, if you don't feel like your overall health is good, you're not going to tap into a lot of resources that you need. You're not going to be able to perform to the absolute best of your ability. You're not going to reach your entire potential. So things that happen in childhood are so, so important for things that happen years down the road. They're not just baby teeth. They don't just fall out. They actually like have consequences for later on. So this insufficient physical development, to kind of go over this a little bit, it means you're not getting adequate nutrition. It's really hard to eat a carrot when your teeth hurt. It's much easier to eat something really soft like pudding or macaroni and cheese, which I love macaroni and cheese, but they're not the most optimal for vitamin content. We know that kids with early childhood caries are shorter in height, and that's one of the metrics. We know that many, many years ago in like the 1700s, everyone was like really short, and now everyone's a lot taller because we have adequate nutrition. Well, these kids, we're sending them back in time. Paradoxically, they might be actually overweight or obese, so they're shorter and whiter. And this is because they might be getting more cariogenic diets, so things that taste good like sugar and candy. In this, there's a lot of things that happen with obesity and a lot of things that happen with caries. They're both multifactorial diseases, so there's no one cause. It's not just because they're eating lots of Snicker bars. But with this increase in adipose tissue, you do get an increase in inflammatory markers, and so children who are obese tend to have more periodontitis, and then in the future, more arthritis. So you're just increasing those inflammatory markers that kind of attack the joints and attack the body, even at a subclinical level until the child gets older. Loss of school days is really important. There's a North Carolina study that showed that children with poor oral health, one, experience more pain, which makes sense, but is also sad. You don't want children to experience pain. But they're also 3 times more likely to miss school. And that if they actually did get to school, they performed poorer on all standardized tests. There was a lot of absences associated with this, but when they looked at the absences for pain versus absences for like going to see your dentist for a cleaning, they found that those absences caused by pain were actually also correlated with that poor school performance. So, which is good news. So you want children to go and seek regular dental care, preventive dental care. Great. Missing school for that doesn't really affect their academic performance. However, when they're missing school because of pain, that is affecting their academic performance, which in turn affects their academic potential and the potential to get a job, and the potential to get off a low SES trajectory and to go onto a higher trajectory. We also see some of the same things out of California. A lot of children were missing school, but a lot were also missing multiple days of school because of dental pain. So this is a study that was just done in 2007. Measuring these studies on how many school days and hours are missed is kind of a hard thing to measure. And every year, there are like 4 million children in this age cohort of school. And so calculating the hours missed, and a lot of it's self-report, it's kind of hard. But what we get is that dentistry and dental pain is one of the things that they're most missed for. I mean, other things are, gastrointestinal infections, like colds, coughs, things like that. But dentistry, for being a preventable disease, gets really a large percentage of those school hours. Most studies will quote around 51 million school hours. Look, when you Google, it's how many school hours are missed to dental caries? And everyone writes it in their grants, 51 million school hours, 51 million school hours. But I read an essay recently by Bert Edelstein. He's like, what matters? It's not the 51 school hours. It's the 1 school hour. It's every single time a child misses class because of a dental infection, because of this preventable disease, they are missing educational opportunities. They're missing social activities with their peers. They're missing anything. So just even that 1 school hour is really important for that individual child. So like I said, oral health related quality of life is a really important metric. Pain, difficulty eating and speaking, difficulty sleeping. A lot of, if you're not sleeping because of dental pain, and I swear, there's not been a good study on this, but dental pain happens between the hours of 7 p.m. and 6 a.m., the most. And I think that has to do with just everything's quieted down, people aren't distracted anymore, but every time parents come in, they say, I have been up all night with my child has been in pain all night. So everyone's difficulty sleeping, not just the child, it's the parent, it's the caregiver. Abscesses, early loss of teeth that lead to future crowding and may lead to the child needing orthodontic treatment. And orthodontic treatment's very expensive. Many insurances don't cover it in this country. There could be damage to the permanent teeth, and there could be life-threatening infection. So this happens when you have big holes in teeth that the infection travels down the tooth, down the roots, into the bone around the tooth. Then you get this abscess or this gum boil, as my people used to say, on the sides. And then you get facial swelling. This usually means a trip to the hospital or to the doctor's office for IV antibiotics, which try putting a 4-year-old, an IV in a 4-year-old, they don't love it. Sometimes they need to be sedated just for the IV. And it also might mean that they might need to have sedation or general anesthesia after. This was my residency program, the operating room in our clinic, and we saw kids 5 days a week, 5 kids a day or more for a preventable disease. So this is the implications of this widespread disease. And we also have some studies that are starting to come out now about taking children really young to the operating room. So if you take them under age 2, we've got some studies that say there might be some possible cognitive effects for young children. And it's not a lot. It's not enough to say okay, we're not going to take you to the operating room to fix all of your teeth, because there's danger in leaving those teeth infected as well. But if you take children to general anesthesia for these teeth, they might lose 1 or 2 IQ points, which, in the grand scheme of things might not mean a lot, but if you're borderline anyway on that socioeconomic track on going up, then that could be a really detriment for you. Again, a very hard thing to study because you're studying it over time. And we know that caries in childhood is the single best predictor of caries in adulthood. So if you've had cavities as a child, you might have them as adult. You're probably going to have them as adult. And things in childhood set those tones for your adult life. It sets the diet that you are used to. If you're really used to eating fruits and vegetables, great, you're probably going to be used to that. Now try getting a 35-year-old to eat fruits and vegetables after a lifetime of eating, candy. Not as easy to do, not as easy to set those habits. Oral hygiene habits, if you're used to flossing, my mother is the best flosser ever. She's flossed from day one. But getting my brother to floss is like a nightmare because he just doesn't do it. It's not a habit for him, but she can't go to bed unless she's flossed. These are things that happen in childhood and set the tone. If children are used to going to the dentist really early, then going as an adult is a normal thing, a normal part of their taking care of themselves. So a lot of these things that affect the adult start in childhood. This includes some oral health beliefs. So my grandparents were like, oh, well, I'll just get dentures. And it took me till dental school to realize, like, oh, not everyone's destined for dentures. Not everyone's destined to lose their teeth. Teeth can be something for a lifetime, which is great. I practiced I did some rotations in Appalachia, where I'm from, and it was really fun. We did this tooth bus, and they had 2 dental chairs, and we'd go around and fix teeth all throughout the mountains, and I had to wear a lot of Dramamine patches because I got really motion sick. But families would be like, oh, well, our family just has soft teeth. That's why we have cavities. And I don't know if anyone here has heard of soft teeth, but there's like a small handful of genetic conditions that cause soft teeth, and none of my families in this program had that. Mostly the soft teeth was a cause of this thing called a rainbow drink, which is, and you can see the baby on the package saying that this is like a good thing for children. Yeah, it's 100% sugar water with some flavoring and food coloring, like no fruit juice at all. In fact, it actually says somewhere like no fruit juice in it. It contains no fruit juice. So the oral health belief that like you're destined to dentures, like we have soft teeth, things like that, those are established in childhood by parents. But you as like community workers and people who are seeing individuals about their oral health in your communities, you can actually change this belief. So you can take them off that trajectory and put them on a trajectory for good oral health, for having their teeth. I tell children in my chair, I'm like, oh, this is great, you have a new adult tooth. You have to keep that until you're 150 years old. After that, I don't care what you do with it. And they're all like, oh, that's weird. I'm like, might not live to 150, but they might, who knows? So that's really important. I want them to value that tooth for the rest of their lives. This is a really complicated model, and I won't read off all the tiny things, but we don't have a lot of stuff in the literature that looks about the LifeCourse framework for oral health, but I think it's important. And I think dental caries and dentistry and oral health in general fits into this model really nicely, just because it's so progressive. And a lot of things that influence oral health also influence the rest of your health, like socioeconomic status, the color of your skin, like what things you like to eat, what things you have access to, your access to medical care, your access to dental care, and things like that, and education, income, stuff like that. So just another like plug that you're doing good things. You're not only helping teeth and things like that, but you're also helping other parts of their trajectory of life. So I just encourage you, if you can keep increasing the protective factors for children, you can get them on that like trajectory to that nice smile, that nice adult oral health, where it might take them off of a social trajectory where they don't have enough, they can't get a job, right? Because if you're gonna hire 2 people and you have one person who has all their teeth and the other person doesn't, and they're equally qualified in all other aspects, you're probably gonna go with the person who has their teeth. So you might elevate someone into a job. You can change that destiny of a child who might otherwise be destined to lose all of their teeth and get dentures, which those are really pretty dentures. I'm glad I don't have to do very many dentures anymore, but those are, you can take them off that trajectory. So no one's destined to not have teeth anymore, which is great. And the interventions you can do now, interventions you can do in childhood can have lasting impact, not only for the rest of that child's life, but their children and their children. So I promised I would get you out of here early because, goodness, it is getting a little snowy out there. But I just applaud all of you, and I'm so honored to have talked today. And I'm just very thankful to be in this great state where everyone, even people who didn't sign up to do dentistry for the rest of their lives, are really invested and involved in improving the oral health care of not only children, but Minnesotans in general. So thank you.
Thank you very much, Lise. Does anybody have any questions for Dr. Sarvos? Specific questions? Yes, Mary Jo. Oh.
Thanks for the enlightening presentation. Learned a lot. My question, or it's a comment, and I'd like to hear what you think about it. But we, at the time that the state does the statewide surveillance activity, the 3rd grade basic screening of randomized sample of 3rd graders throughout Minnesota, We also collect height and weight data. We collect oral health and height and weight at the same time. And we haven't had a chance to analyze our 2015 data. We have around the oral health status, but we haven't really had a chance to look at some of the height and weight data. But the 2010 BSS showed, we were looking for obesity and overweight, but we actually found that there's perhaps more of a correlation between poor oral health and underweight. And so I'm thinking that we think logically it's got to be connected to obesity because of sugar, the relationship to sugar, but we found in our 2010 BSS that there's some indication that it could be more related to underweight. So that's kind of interesting. We haven't had a chance to look at it.
No, I think that highlights the importance of population studies and like nice big populations. Like Minnesota does a really nice job of every 5 years going out into the field and testing their children, which not all states do, and they should. And I applaud your efforts for getting out there. We know that sometimes high caries rates and poor oral health is also starting to be correlated with food insecurity, which is also correlated with low socioeconomic status, children of color, and things like that. So if you're not getting the food that you need, if you're going to school hungry and in pain, that also puts you on that lower trajectory for life. So certainly something to think at and keep looking at.
Any other questions? Anyone? Well, thank you very much. We are so blessed and fortunate to have you here with us today, too, and I really look forward to working more closely with you on some of our other initiatives, too. So let's just give her another round of applause.